Hello, friends. This is Dr. Aishvarya Kaushik, your original guru for endodontics, conservative dentistry, and dental materials. Friends, today we are going to discuss a case in my practice in which an 18-year-old male patient reported to us with a traumatic injury in his upper anteriors. Right, friends? So there was, severe fracture, crown fracture. No root fracture. We had ruled out the root fractures by taking x-rays at different angulations. There was no luxation injury. The teeth were not mobile. The entire injury, the entire impact was sustained by the crown, in which the crown fractured. The crowns of upper, central, and lateral incisors of the second quadrant fractured. And we had to have and we did the job of doing root canal, post and core, and giving all ceramic crowns on the teeth, relieving the patient of his severe pain, number one, and secondly, and very importantly, a young patient, 18-year-old. So we restored good aesthetics. So this is how the stepwise procedure of doing the case, friends. All right. So as you can see here, now this is the clinical presentation of the patient, guys. So you can see here the upper left central incisor and the lateral incisor. Apparently, guys, as you can see here, yeah, the lateral incisor, as you can see, guys, almost, less than half of the tooth structure is remaining. I observed the, pre-trauma, asked the patient to get his pre-trauma photographs for us. We observed those and we realized that more than half of the tooth structure is gone. Similarly, for the central incisor, yes, around the mesial surface, you do have some length of the tooth that is remaining. But if you see the distal angle, right about here, practically nothing is left. You're right at the level of the gingiva. So we decided that we have to go in order to, provide a definitive treatment, long-lasting treatment to this patient. You have to go for a full coverage crown in both the teeth. On top of that, because the residual tooth structure that is remaining is so less, you have to restore it with a post and core. Because as you know, if you go by Cohen, if you have less than extensive damage to the tooth structure, as well as less than 50% or half of the tooth structure that is remaining, you have to go for a post and core. In order to do a post and core, you have to do a root canal treatment, isn't it? No harm in doing it. You have an exposed, Elise class 3 type of a situation. Even if, this is a mature tooth, guys. So I would suggest that if you're planning for a definitive crown and you realize that if you do a direct build-up and then do a crown, it won't sustain. You need to have a core build-up which will last for a long period of time, because only then your crown will be there. So in such a situation, even if you have very less, remaining dentine thickness, in which ideally could have gone for a direct composite restoration, in this case, there is no point of trying for apexogenesis, no point of doing vital pulp therapy. The tooth is mature. The patient is 18 year old. The root apex is formed. You have to plan for a post and core, go for root canal treatment, do a post and core, give definitive restoration. So as you can see, guys, here after doing root canal treatment, yeah. So after performing root canal treatment, I did post and core buildup, right? Then we did crown preps. You can see here we have some nice, equigingival margins, right? Prepared some nice equigingival margins, gave some nice taper to the tooth, right? And then we did our nice shade selection. The shade was selected as A2, right? And then we went for PFZ, zirconia PFZ crowns. What is PFZ? Porcelain fused to zirconia crowns, guys. As you can see, yeah, that's your crown prep. We took impressions in affinous light body and putty. And as you can see here, guys, the patient was extremely happy. You can see the great emergence profile, wonderful, nice emergence profile, no gap at the gingival margin. Very nice shade selection, right? A2 shade, bang on. The patient was very happy. Occlusion required very minor adjustment. I got great lab support. And here we have a happy patient in our practice. Right, guys? So very sequential, stepwise, meticulous treatment planning. That is what we did in my practice here. We wanted to do some definitive treatment and not just, provisional treatment for this patient. As I said, young patient. We gave he was happy with the result, and this is how we have restored not just his confidence, his smile, but also when he presented to us, he was in severe pain. That was obviously, traumatic injury, very close to the pulp. For all practical purposes, there were micro exposures to the pulp. As I said, in such a situation in which you do not have a frank pulpal exposure, you would classify this as an Ellis class 2. However, as you can see, doing a direct composite buildup, which is the ideal treatment in such a case, just see you have to assess other things also, isn't it? According to Cohen, you're not just seeing the amount of, just one aspect, that is, you have to see the residual remaining tooth structure that is there. You have to assess the functional occlusion. Now, this guy has a edge-to-edge bite. If you give him a direct composite restoration, going by the ideal standards of, managing an Ellis class 2, in which you feel like, preserving the pulp in this situation, practically the second or the third day, the patient is going to come back with a fractured restoration, right, guys? So, in such situations where you have loss of tooth structure, which is more than 50% of the original tooth structure, your functional occlusion, is not ideal. His bite is not ideal. It's an end-on bite, edge to edge. The lower anteriors are, hitting the upper anterior incisal edge. You have to, sometimes think out of the box. You have to make a customized treatment plan for these patients for sustainable long-term treatment. Right, guys? Thank you so much. Best wishes.